The first speaker is Ben Abella. He's the director of the Center for Resuscitation Science at Penn and a professor of emergency medicine. His work focuses on topics of cardiac arrest and post-arrest hypothermia treatment. He's authored review monographs and textbook chapters on cardiac arrest and resuscitation. His talk is entitled Updates on Penn Initiatives in the Community to Address COVID-19.
Terrific. So thanks for that introduction. As stated, I'm a faculty member here in emergency medicine, where I've worked at Penn for the last 15 years, and I'm vice chair for research in the department. While formerly, and continuing to this day, much of my work is in cardiac arrest and post-arrest care. Like many of us, the COVID pandemic has created important avenues to contribute to something that affects all of us. So I've become a bit of a COVID implementation researcher of sorts over the last few slides with you all here. So let's see. Okay, so let's see if this is working. Hopefully you should see my slideshow momentarily. What I'm going to do today is share with you some of the work done within emergency medicine and our collaborators regarding really initiatives to address at the community level this pandemic. So I'll be talking about a number of avenues to this. Before I launch in, hopefully everyone can see my slides. Just a quick feedback from someone would be great.
Yes.
Terrific, great. So there are many ways to think about how to address COVID-19 and how to implement community-based solutions to improving care. For the purpose of this talk, I've grouped them into these 4 buckets, if you will. Of course, the treatment itself of the disease and its disease course is very challenging. As emergency providers, we've been on the front lines of this and very much in the thick of treating COVID patients. And I can tell you that one of the major challenges we face, unlike many other acute emergent illnesses, often patients present early and appear reasonably stable, but then instability or significant disease can develop much later. So there's this sort of latency to the disease that makes treating ambulatory COVID very difficult. So that's one area. And then, of course, even before that, there are a number of really challenging issues, including the impact of both managing the disease, but then managing testing and vaccination with regards to disadvantaged populations, racial, socioeconomic inequities, and such. And these I've displayed here. And this talk is basically going to be organized into these 4 buckets in areas where we have done some work to try to combat these. So this is going to be a survey of work, some by my group, but some by others in my department, and I'll highlight those as I go along. So first off, to focus on the disease itself and how we in emergency medicine think about treating COVID, and are there ways to address this latency issue to improve care and improve outcomes? This is work led by Kit Delgado, an investigator in emergency medicine and a large multidisciplinary team. They have done work both implementing and then evaluating a program called COVID Watch. Many of you may be familiar with this, but I'm going to do a brief review of what COVID Watch is. But this is an important solution to use digital technology and innovative tools to continue to keep patients who have ambulatory COVID within our purview, within our reach, to be alert to any decompensations that might occur. And so what is COVID Watch? Well, that recognized, or I should say the investigators recognized, that it's not enough to see patients, say you have ambulatory disease, you're going to go home, and to not stay in touch, because people can deteriorate somewhat rapidly, and there are established treatments that can alter the trajectory of disease. For example, dexamethasone, when given correctly for the right patients, can improve outcomes. Early use of oxygenation strategies, certainly for severe COVID, intubation or other airway management as appropriate. So it's important to know when these things happen, and it just isn't effective to have providers following up on everybody, especially in the height of the disease pandemic, to have actual providers stay in touch with all these patients. And so they developed an app for automated clinical monitoring. So the basic idea here is that adults with diagnosed COVID illness could be enrolled, and they could be enrolled, say, by emergency physicians, by nurses, by physician's assistants in the clinics or in the emergency departments via Epic. So there was an EHR order that would allow linkage to this app. And what it would be is it would just be a text messaging. So people would not have to download an app. Importantly, patients would not have to have established care at Penn. So they didn't have to be within the Penn system or My Penn Medicine. They could be linked to this. And it was a very simple framework, which of course is important to keep it simple, where patients who enrolled would have twice daily contact with one primary initial question. How are you feeling compared to 12 hours ago? Better, same, or worse? And that was it. And if they said worse, it triggered another question about breathing. And is your breathing a problem? And if that was a yes, then it would trigger contact with a provider. So this was essentially a way to stay in touch with patients and afford some level of monitoring through their phones. Patients would be enrolled for 14 days with an option for 7 days beyond that if they chose to do so. And patients who were enrolled between March and November in this pilot analysis, they had to have a positive COVID test. They had to have confirmed COVID disease and not be hospitalized. And so in this analysis that Kit and colleagues did, over 7,000 patients were enrolled, and they were either in a COVID watch arm or usual care where they were not in COVID. This wasn't a randomized trial, so there was some initial differences in these groups. People in COVID watch were more likely to be Black, lower income, have other comorbidities, and lack primary care. Indeed, this is probably one of the motivators why they may have joined COVID watch. The results were truly remarkable, and I can say that these results are in press right now at Annals of Internal Medicine, but this has been presented in abstract form by Kit and others, and I certainly have his permission to share these data today, that there was a direct reduction in death, a measurable reduction in death by the use. It was important, of course, to do propensity scoring because, as I had mentioned, these populations have some significant differences in their nature as a non-direct randomized trial. But I would highlight a couple of things. If you look at out-of-hospital deaths in COVID watch versus usual care, there were no out-of-hospital deaths among users of COVID watch. Whereas there were certainly out-of-hospital deaths with usual care. And this is, of course, one of the big problems that people would decompensate at home and not make it to the hospital. Overall, there was an important risk reduction, and the number needed to treat of 400 suggested that several lives were saved per week. And this is an automated app, and remarkably, only several providers, I think 2 or 3 at most, were ever in service to manage over 1,000 patients at a time. So this was a very sort of cost-effective and useful way to put technology to work. Also importantly, this benefit was seen across all racial groups, and I show you here some data there, that white, Black, and Hispanic subgroups all had reduced mortality. And I should point out that the app had a Spanish language version as well. So this was an important way to access populations that might not have the same infrastructure of health with primary care follow-up and such. So a very important contribution there. Now, how would this work? Well, to get at the mechanisms of this, it seemed that patients in COVID watch, perhaps unsurprisingly, had more clinical interactions. If it triggered a provider to contact the patient, often they were sent to the ER or encouraged to seek emergency care. And so there's more clinical interactions that may very well have led to earlier intervention. So, for example, the employment of dexamethasone or other interventions was several days earlier in the COVID watch group versus usual care. So in summary, COVID watch improved survival, and it probably did so because we were able to trigger interventions in populations. And this is, we feel especially proud of this work in that it was really outreach to populations that needed this resource, Black populations, Hispanic populations, many without primary care providers. So this is a very sort of powerful example of how technology can combat disparities. You know, other work led by Dr. Delgado and colleagues have looked at whether this app could be combined with the use of an oxygen, a pulse ox sensor that people were sent home with. And this work will be analyzed and reported soon. So that's treating the disease itself. What about testing? Because after all, first and foremost, we need to make sure people get tested for COVID so that they know to quarantine, so that they know to get evaluated. And this is a major problem that has socioeconomic structural disparities across our communities. And so this is the work that through funding through the Department of Health in Philadelphia, I'm proud to say my team has undertaken community testing in partnership with two large community groups in Philadelphia, one Prevention Point, a group that works with primarily opioid use disorder and recovering opioid use disorder patients, and also the Philadelphia AIDS Consortium. This is our team that spans across emergency. And the basic idea here is essentially a pop-up mobile testing infrastructure that would go to the community. And this is an important lesson, I think, for those who are interested in combating disparities and working with communities. You really have to go to the community. You have to meet them where they are. And so we would set up mobile testing sites. And indeed, this very day, as I give this talk, we have a mobile testing site in Kensington that's active right now. At strategic locations where we've worked with these community groups, find partnerships, and attract people for free testing. Now, importantly, not only do we provide testing, both rapid antigen testing and PCR testing, but we couple this with a general harm reduction strategy. So we give out other resources, including Narcan for opioid use, managed salvage for people with opioid use overdose. Also, we give out simple things, gloves, masks, hand sanitizer. So we sort of use this as a point of resource provision for disadvantaged communities. And that, of course, draws more people to get tested and keeps community engagement. We've tested many people through this. And as you see here from the demographic breakdown, Latinos have figured large, as have African Americans in our population. The age is spanned, as you might expect, all across the map as a community-facing volunteer program. Importantly, we reach people also with important socioeconomic disparities. And many of you know, of course, that education is an important surrogate for that. And you see here that many of the people we've tested and educated through our program have only had high school or GED level education. Importantly also, many of them are undomiciled or housing insecure, which is an important impact on testing and treatment, of course, and a major problem in current times in Philadelphia and many cities. These are the positivities for our program, and this is sort of overall and not uncommon to see this sort of rate currently across Philadelphia and other testing programs. But because we do both rapid and PCR testing, it speaks to the importance of bringing this PCR testing to the community, as the rapid antigen tests, while often provided in many clinics in broad communities, you have a lot of false negatives among asymptomatic people. So we feel this double testing strategy allows for more capture of positivity to allow people to quarantine and make healthcare decisions. Okay, and so here's positivity rate by demographics. And one thing I would point out from this is that the Hispanic community, and this has been shown in other cities and other groups, has been hit especially hard. Hispanic Philadelphia often have much access to healthcare resources, and importantly, for employment purposes, they often, for family sustenance purposes, often do not have the luxury of being able to quarantine. And they often have jobs that put them in harm's way because these are service jobs that often interact with much of the public, whether they wish to do so or not. So that's some work we've been doing in testing, and that work continues to this day. Well, what about access to vaccinations? Another very important issue. Of course, disadvantaged populations often have reasons. So we've done some work there as well, and I'll share with you two programs being led by members of our department, of course, in partnership with many others at Penn, both a vaccination program within the emergency departments and also partnerships with the community for vaccination access. And so I should highlight the work of Julie Usball, one of my colleagues and a tremendous clinical leader in our department, who has worked with others in and outside the department to recognize that emergency departments are often not only the front lines of care during the COVID pandemic, but the front lines of access, the front lines of capture for vaccination and testing. And so in just this May, we recognized that we had a supply of Johnson & Johnson vaccine. This is the one-shot vaccine that was set to expire. And so Julie and others recognized, well, one shot as opposed to vaccine series is perfect as a point of capture opportunity in the emergency department. And this batch was set to expire, and so the thought was to get shots in arms. And so we established a program in our emergency department to offer the Johnson & Johnson shot at no cost to people who said they were not vaccinated and might be interested in doing so. So this really capitalizes on this notion of a point of capture, using the ED as that point. And this, it wasn't just in the HUP ED. This was done across our West Philadelphia and Center City locations, so Presbyterian, Pennsylvania, and HUP. And during the height of the pandemic, of course, we were seeing large patient volumes. We still see COVID positive patients every day, but at the peak, large patient volumes. And we felt this was a great opportunity. And each site undertook a different strategy. At Presbyterian, there were pharmacy groups that would sort of move around and seek patients, but they were primarily dedicated to this. At Pennsylvania Hospital, at the end of each day, when there was surplus vaccines from other vaccination programs, it would be brought to bear to patients who wanted it. But at HUP, which is actually the model that's sort of been the most sustainable, it was integrated directly into clinical care. So at HUP, patients would be flagged as being unvaccinated and interested, and then the care team, the nurses at the bedside, would provide the vaccine. And so this involved a wonderful collaboration between many stakeholders, because many questions would come up about appropriateness of vaccination for given populations. So we thank them for their involvement, and certainly hospital leadership. Many at HUP and across the system were instrumental in helping us get this off the ground, and it continues to this day. And I might close this with an anecdote. It's not data, but it's important anecdote, and I'll show you data on the next slide. One patient is talked about, Julie shared with me this story, a patient who was wheelchair bound with cerebral palsy and was cared for by her elderly mother. Now, you could imagine this is a setup. This patient is at risk. They're wheelchair bound. Their pulmonary condition is not ideal, and they may very well have difficult access. Well, the vaccine was offered and given to them in the ED, and it's reflected to me that both the mother and the patient burst into tears with relief that they finally were able to get the vaccine and prevent COVID, and the patient is gotten through the pandemic. So a real emotional impact on the providers who are involved, and certainly we see these stories with some frequency. So here's some of the demographics of our vaccination program. This is just from HUP. And you can see that patients may have come for a variety of different conditions. That was less important. Of course, what really we're asking them, were they previously vaccinated? And if they were not, we offered them vaccination. Now, the second piece to share in vaccination outreach is work by Gina South and a large community consortium. Also, Kat Lee, one of our physicians who has left for other positions and no longer at Penn. Unfortunately, we miss her. They were very instrumental in setting up a collaborative in West Philadelphia. And so here's a list of many of the people who are involved in this. And we, Phil O'Calla, PJ Brennan, Pat Sullivan, we thank them. They were very instrumental in championing this in the West Philadelphia communities. And we worked with local churches and other organizations to, by we, I mean Gina, Kat, and others, to set this up. And this was work also done in conjunction with Mercy, now of course known as HUP Cedar. The idea here was the recognition that there was enormous disparities that exist to this day, racial disparities in vaccination rates. And I show you here vaccination rates across the country, where you can see an across-the-board disparity between the Black percentage in the general population and then in the vaccinated population. And so this has also been shown at the level of availability at retail pharmacies, where, for example, this evaluation at Rite Aid showed that most doses through retail pharmacies are going to white populations, not African Americans, not Blacks. And so they undertook this partnership in West Philadelphia that involves rapid cycle innovation, where innovate to make it work for people. And one of the early recognitions was this had to be low tech. We couldn't use My Penn Medicine, and we couldn't use signing up for a clinic. It had to be very easily accessible. And clinic flows were set up for rapid vaccination. So people would come in, come out sort of very ready flow. They didn't want lots of lines, lots of people waiting around because they just might not get it. And the other sort of key aspect that I think is a broader lesson from combating disparities in many diseases, it has to be a partnership. Like I mentioned before, going to the community, it also has to be a matter of trust and building that trust that this isn't sort of us coming in from the outside to solve their problems, but working with them to help them and see what they needed. And so there was a lot of work with faith organizations and other groups in the community to do this. An app was employed that would just send text messages for signup. So again, they didn't have to download an app, but there would be a ready text messaging thing to do rapid signup. So they could get vaccine right away and more shots in arms. So here's just a couple of example screenshots so you can see that you could easily schedule just through your phone through an automated app. And it was all paper-based. The thought was, let's not get complicated here with bringing EHR and bringing computers. So everything was done as simply as possible to develop a good culture of training and vaccination. And just to give you some examples, here are some of the sites that were set up, and large numbers of people were vaccinated through this approach, primarily African American, which after all was one of the goals. And these are populations that really, as you saw, had a gap. So this was directly combating these disparities in vaccination. And here you see a picture of many of the people and even one of the canines involved in some of this work. This is at Hupcedar, and this work was really, I think, a shining example of how Penn and Penn Cedar are directly engaged in the community and active in combating these disparities. Then finally, as the last issue I want to cover today, and then we can take some questions, there's the issue of racial socioeconomic inequities and mistrust. So, why are there these disparities? Well, some of them are certainly economic and structural, but some of them are beyond that. And we wanted to delve into this. And one of the ways we did so was doing a survey in Hupp and Penn Presbyterian emergency departments. And this is work that's now been published in Academic Emergency Medicine, inquiring about vaccine hesitancy and some of the motivators and issues surrounding hesitancy in our population. I'm proud to say this is one of the first papers to look at hesitancy from the perspective of urban emergency departments. And so it's generated some conversation in the emergency medicine community nationally. These are some data from our paper, and just to show you that predominantly Black population, over 70% Black, with a wide range in education and employment status, as we typically see in our emergency departments. We asked everyone in this survey study a question, that if a vaccine was available to you today, would you take it? And we defined saying no to that question as hesitant. And that doesn't mean hesitant forever. That just means hesitant at the time of the question. And over 30% of people said were a vaccine offered them today, they would not receive it. And these are people who are unvaccinated. So this is fairly consistent with other studies that have looked at hesitancy and found a large minority of people are indeed reluctant to get the vaccine. Now, what we found was interesting when we put this through a regression model was that African Americans and other non-white races, except for Asian, were much more likely to be hesitant. Younger people were much more likely to be hesitant. And this was a stronger impact than education. So there was something deeper than just educational level at play here that may speak to culture or trust issues, which led us to ask questions about trusted health information. That is to say, if you were to hear that you should get vaccinated and that information were to come from various groups, how would it impact you? And one of the striking findings in our work was that the vaccine hesitant group was very much less likely to trust government communications. So information directly from the CDC or NIH was just less likely to make an impact in this group. And we took some qualitative information on this. And it really speaks to, I think, an important cultural point that mistrust of government runs deep in populations that suffer disparities. So why would it be any different with COVID? So this suggests anyway, tangentially, that perhaps dollars could be better spent than large full-scale campaigns by the CDC, working through, say, smaller micro-targeting, family, friends, other groups that are more impactful to these populations. So that was, I think, one of our big findings. That speaks to one of the challenges we all face in getting correct information into these populations. And so there's many ongoing needs. I think community level education for both misinformation, for testing, for vaccination remains important. Through some of the work of our department and others, we've certainly increased access, but there's a long way to go there. And I think one of the ways to do this is certainly through vaccination opportunities in the emergency departments within Penn and outside of Penn as well. I just want to highlight our team. You know, Penn Emergency Medicine has really been at the forefront of this. Many of our providers have had COVID and recovered from COVID, but I'm deeply proud to be part of this community who really took on the pandemic head on. And I show you here some of our providers and researchers in various stages of the pandemic and the work that they did. I also want to highlight in the top right there, in the 4 people wearing dark blue scrubs. These were people who were very involved in our hydroxychloroquine randomized trial, where we found that hydroxychloroquine was ineffective as engaged many emergency providers and others at the front lines within Penn who voluntarily were subjects in our study to take hydroxychloroquine or placebo. So I thank all of them as well. And with that, I wanted to leave some time for questions and discussion. So I think we're sort of right on time to have a 5 to 10 minute discussion period if that's of interest.
Okay, can you hear me now, Susan? Yeah. There's one question in the Q&A, and I'll get to it in a moment. But meanwhile, please put some more questions in. We do have time. We're kind of ahead of schedule even. So Ben, here's a question for you from Alex Arvanitis. Spanish language COVID vaccine disinformation is a major problem that, unlike its English counterpart, goes largely unrefuted. Do you know if there are any Spanish community outreach measures that could be paired with the monitoring app to produce better outcomes?
Yeah, thank you, Alex. That is a very important question. And, you know, I unfortunately, this is an area that needs a lot more work. And needs a lot more work in many communities, Philadelphia being one of them. Many of you may know that Penn proudly partners with an organization called Puentes de Salud, which is a primarily a Mexican-facing or Mexican immigrant-facing organization in Philadelphia. And they've done a lot of work locally in this area, but nationally, you're quite right. Spanish language disinformation is a major problem. We have not done work in this area, but I know some other groups have been. Puentes has been a little bit involved, as I say, locally. Nationally, however, certainly there have been efforts in the online misinformation and some Facebook groups and others, but I think this is an area that quite honestly has been under-resourced and underappreciated. So if nothing else, I thank you for the question to highlight this as a major issue. As many of you know, Latinos are especially bearing the brunt of this in states like Texas and Florida, where for a variety of reasons, both large Hispanic populations and also sort of state actions and sort of health initiatives or lack thereof have impacted Hispanics to a very tragic degree.
Thank you, Ben. Any other questions before we go on? Any more? Do you want to make any more comments, Ben, or you're done?
Well, no, no. I mean, I think reservoirs of disease in those who are housing insecure and disadvantaged. So I would encourage all of us to think about these problems. You know, I think when we say X number of people in the population are vaccinated, we have to think who they are. And just like in you know, think about those of you who are familiar with tuberculosis and the history of TB. You know, TB in many middle class and sort of quote unquote wealthy communities and societies is largely eradicated, but that doesn't mean the disease is gone. And there are, of course, areas that have a lot of tuberculosis due to socioeconomic problems and public health problems. So I fear that COVID will be prolonged if we don't address some of these issues moving forward.
All right, we do have another question now from Patrick Cherubin. Thanks for this talk, Ben. What do you think can be done differently to combat vaccine hesitancy in low-income communities, more specifically African American? Take into account historical context that may have triggered hesitancy.
Absolutely. So thank you for that point and that question. Yeah, certainly a lot of mistrust around vaccination and health infrastructure is well-founded and based in a lot of very important historical precedents. Many of you know them. I think we don't have time to go through many of them, but just know that this is not an irrational mistrust, but rather a mistrust based deeply on experience. And so this is something that it should be done differently. And I think one of the things that our work showed us is that the top-down approach, government, there, public health infrastructure saying you should get vaccinated, that's not going to be as effective perhaps as peer-to-peer or engaging with African American communities directly to have local sponsors, local advocates. And I think not enough work is being done there, but in the communities that have done that, as we saw through Gina and Kat's work in the community, it can be very effective.
Okay, I think that's it. And thank you very much for that really interesting talk.